think about the thyroid gland. You know, that small butterfly-shaped gland with
Yeah.
such a massive job regulating things.
Absolutely. It controls so much.
Now, imagine that regulator completely failing, leading to a crisis so severe it actually becomes life-threatening. We're talking about Myxoedema Coma.
Yeah. It sounds extreme, doesn't it?
It does. But understanding this sort of worst-case scenario isn't just about a rare condition. It really helps you grasp the thyroid's role and why managing it is so crucial.
Exactly. Myxoedema coma, well, thankfully it is uncommon, but it represents the most critical end of the hypothyroidism spectrum.
All right.
You've got this profound lack of thyroid hormones causing widespread chaos in the body,
Yeah.
and critically, a major change in mental state.
It really highlights why keeping that thyroid healthy or well managed if there's an issue is so vital.
Exactly.
And that's what we're really digging into today, using these comprehensive revision notes you've pulled together as our map.
Sounds good.
Our mission really is to pull out the absolute must-knows on Myxoedema Coma for revision. Keep it clear, concise, something that actually sticks.
Yeah, cut through the noise.
Exactly. And to help us unpack all this and, pinpoint those really crucial bits, we've got our expert right here.
Happy to be here. So maybe let's start with the definition again. Just nail that down.
Good idea.
Okay, so Myxoedema coma. It's a severe life-threatening state. It comes from untreated or maybe poorly managed hypothyroidism.
So not just mild low thyroid.
No. The key is a profound deficiency in thyroid hormone levels, often over a long time. And this triggers severe effects right across the body systems, leading to, crucially, that altered mental status.
Altered mental status. So confusion or worse.
Yes, ranging from confusion right through to coma. Think of it as like severe underactive thyroid that's gone catastrophically wrong.
Okay, got it. So it's way beyond just feeling a bit tired then. What actually kicks this off? What's the root cause, the etiology?
Well, the primary cause, fundamentally, is the thyroid gland itself failing. It just stops producing enough thyroid hormone.
The gland itself packs in.
Pretty much. And if that severe hypothyroidism isn't picked up or it's not treated adequately over a long period, well, that's the main path towards this crisis state, like a factory making a vital product just shutting down.
Okay. And are there things that make someone with hypothyroidism more sort of vulnerable to this escalating? What are the risk factors?
Yeah, there definitely are. The most obvious one is simply having untreated hypothyroidism. If it's not managed, the risk just climbs.
Makes sense.
And then there's poor compliance, not taking the thyroid hormone replacement properly or consistently. That's a big one.
Right. People stopping their medication.
Exactly. Demographically, it's more common in older people, typically over 60. And it's also seen more in women.
Why women?
Well, hypothyroidism itself is just more common in women, especially older women, so there's a clear link there. And finally, having pre-existing cardiovascular disease seems to up the risk too.
So like the body's already under a bit of strain.
Sort of, yeah. Less able to cope with this extra, really severe hormonal hit.
Right. Okay. So a mix of the underlying condition and maybe other health issues. Now, what's actually going on inside the body? What's the pathophysiology here? How does it cause this system-wide shutdown?
Okay, so at the heart of it, those drastically reduced thyroid hormones mean a massive slowdown of all metabolic processes.
Everything just grinds down.
Exactly, like the body's engine running incredibly slowly. And this has effects everywhere. Cardiac output drops. The heart just isn't pumping as effectively. Hypothermia sets in because the body isn't generating enough heat. Often you'll see a core temperature below 35.5 degrees Celsius.
That's really cold.
It is. Then you can get electrolyte problems, especially low sodium hyponatremia. Breathing becomes shallow, inefficient, leading to a buildup of CO2 that's hypoventilation.
Okay.
And as we said, brain function is severely hit. Altered mental status, confusion, right up to coma. The body tries to compensate for a while.
But it gets overwhelmed.
Exactly. Especially if something else comes along, a trigger.
The precipitating factors.
Yeah.
Right. What kind of things can push someone over the edge?
These are the events that tip the balance in an already struggling system. Hypothermia itself can be a trigger, actually. It creates a vicious cycle.
Worsening the slowdown.
Precisely. Infections are a really big one. Things like pneumonia, flu, UTIs, they put extra stress on the body.
Okay.
Stopping the thyroid replacement therapy, that's a direct, major risk. And certain medications can interfere too.
Like what?
Well, the list includes amiodarone, some anesthetics, beta blockers, diuretics, drugs that act on the central nervous system, lithium, phenytoin, rifampicin.
Quite a few then.
Yeah. And finally, just general physiological stresses, things like low blood sugar, hypoglycemia, GI bleeds, stroke, surgery, trauma, accidents, anything that messes with breathing.
Wow, okay. That's a pretty wide net of potential triggers.
Yeah.
So if someone comes in looking like this, how do doctors tell it apart from other serious stuff? What's the differential diagnosis look like?
That's absolutely crucial because getting the treatment right quickly is everything. Myxoedema coma can look a lot like other critical illnesses.
Right.
So you have to consider sepsis that can also cause altered mental status, low temperature sometimes. Congestive heart failure causes fatigue, fluid retention.
So more symptoms.
Exactly. Simple hypothermia from being out in the cold needs ruling out. And of course, various primary brain problems can cause mental state changes.
Okay.
More specifically, if the main thing you're seeing is that deterioration in mental function, you're thinking sepsis again, maybe severe psychiatric issues like depression or dementia, other medical conditions, drug side effects, respiratory failure, stroke.
It's a detective job then.
It really is. You have to look at the whole picture, all the clues, and systematically rule things out.
Okay. So how often does this actually happen? Is it common? What's the epidemiology like, UK and worldwide?
Well, specific UK figures are hard to come by, but it's definitely considered rare here. Looking globally gives a bit more perspective. Japan reports maybe 1 case per million people per year. In Western countries, it seems even lower, perhaps 0.2 per million per year. So really uncommon.
Very rare indeed.
Yeah. And we see that strong female link again about 4 times more common in women, which, as we said, probably tracks with the higher rates of hypothyroidism in women over 50.
Right.
It also tends to hit older adults, usually over 60. And interestingly, it's a bit more common in places with iodine deficiency parts of Asia, Africa, South America.
Because iodine deficiency causes hypothyroidism.
Exactly. There's even a seasonal thing. About 90% of cases seem to pop up in winter, possibly linked to older people having more trouble regulating temperature.
That's interesting.
But the key takeaway is it usually happens in someone with long-standing hypothyroidism that's either not been diagnosed or hasn't been treated properly, and then some trigger infection, stopping meds, whatever pushes them into crisis.
Got it. That really clarifies the context. So let's talk about presentation. What are the key signs and symptoms we should actually look for?
Okay, the classic textbook picture includes extreme fatigue, that low body temperature hypothermia, often below 35.5 degrees C, a slow heart rate bradycardia, low blood pressure hypotension, shallow breathing respiratory depression, and that altered mental state from confusion up to coma.
And the edema.
Yes, non-pitting edema is often mentioned, that swelling that doesn't leave a dent. But here's a really important point.
Okay.
Most patients don't initially present in a deep coma or with really obvious non-pitting edema. It can be much more subtle at first.
Oh, okay. Good to know.
Often there's that background of long-standing hypothyroidism, so you might see those classic signs too. Weight gain, just persistent fatigue, constipation, can't stand the cold, maybe coarse hair, a deeper voice, dry, pale skin. That sort of thing.
Right. So look for the background signs too.
Definitely. And we can break down the effects system by system. Central nervous system. You see the mental decline, confusion, apathy, maybe even psychosis rarely, or progressing to stupor or coma. Reflexes might be sluggish, slow to relax. Metabolically, that slow rate causes weight gain, low energy, problems clearing drugs from the system. And the hypothermia and breathing problems are key, leading to acidosis, low oxygen, high CO2.
Right.
Then there's the classic facial appearance, kind of generalized puffiness, maybe a large tongue, macroglossia, droopy eyelids, haematosis, swelling around the eyes, coarse, sparse hair.
Quite distinctive sometimes.
Can be. The skin often feels dry, cool, maybe a bit doughy. That non-pitting edema can appear on hands and feet. Hair loss, too.
Okay. And heart.
Cardiovascularly. Slow heart rate, reduced pumping strength. Sometimes fluid around the heart, pericardial effusions. You might see that as an enlarged heart on a chest x-ray. Increased resistance in the blood vessels. Heart sounds might be muffled.
And gut.
Gut issues, yeah. Constipation is common. In really severe cases, you can get a massively dilated colon, myxoedema megacolon, or even a paralyzed bowel, paralytic ileus. Kidneys can be impaired. Bladder might retain urine.
Wow. And breathing.
Respiratory system takes a hit too. Weak breathing muscles, less drive to breathe from the brainstem. So shallow breathing, low oxygen, high CO2. Sleep apnea can happen too, often linked to the weight gain.
That's a really thorough picture of how widespread the effects are. So if a doctor suspects this, what are the crucial tests, the investigations?
Right. Diagnosis needs to be quick. The absolute cornerstone is thyroid function tests, TFTs.
Okay.
Typically, you'll find a very, very high TSH, that's the pituitary shouting at the thyroid, and then very low T4 and T3, the actual hormones.
Usually high TSH, low T4, T3.
Usually. But remember, very rarely, if it's a pituitary problem causing it, TSH might be normal or low, so you need the T4, T3 as well.
Got him. What else?
Routine bloods, like urea and electrolytes, urinase, often show low sodium hyponatremia. Creatinine is usually up, showing kidney strain. Blood sugar is often low, hypoglycemia.
Okay.
Full blood count might show a mild anemia. Need blood and urine cultures to hunt for infection. Oxygen saturation will likely be low.
Makes sense.
Blood gases are vital. They'll show the low oxygen, high carbon dioxide, the respiratory acidosis. Serum enzymes like creatine kinase, CCK, are often high, usually from muscle. Lipids might be high too.
Right. And heart tests.
Yep, and ECG. Can show the bradycardia, other nonspecific changes, low voltages sometimes, heart block, prolonged QT interval. Need to think about potential MI too.
Okay. Imaging.
Chest x-ray is useful, can show fluid on the lungs, pleural effusions, or that enlarged heart from a pericardial effusion.
Anything else vital?
Yes, serum cortisol level. Really important to rule out adrenal insufficiency, especially if you suspect a pituitary cause. And as I said, a thorough infection screen blood, urine cultures, maybe more depending on the picture, is critical to find any triggers.
Okay, quite a battery of tests needed quickly. Given how serious this is, what's the immediate game plan? The management.
It's a full-blown medical emergency, needs immediate hospital admission, straight to intensive care, or at least a high dependency unit.
Right, ICHTU.
Absolutely. The key is rapid action. The main pillars are intravenous, the Phi thyroid hormone replacement, usually levothyroxine T4, to get those hormone levels up quickly.
IV, not oral.
IV initially, yeah, because gut absorption can be really unreliable in this state. Then IV fluids are usually needed for resuscitation, support blood pressure.
Okay.
Correcting electrolyte imbalances, especially that low sodium, needs careful management. And IV corticosteroids, usually hydrocortisone.
Why steroids?
Mainly because adrenal insufficiency can coexist, especially with pituitary problems, or it can be triggered by the stress. You can't wait for tests to rule it out, so you treat empirically upfront.
Got it. Treat just in case.
Exactly. And if they're hypothermic, gentle rewarming. But importantly, avoid rapid external warming, like with heating blankets. That can cause blood vessels to dilate too quickly and drop blood pressure dangerously.
Slow and steady rewarming.
Precisely. In ICU, they might need mechanical ventilation to help with breathing. Continuous ECG monitoring is vital. Careful fluid balance, managing blood sugar. It's intensive supportive care alongside the specific treatments.
And the thyroid hormone replacement, it's any specifics there?
Yeah, there's actually a bit of debate. Should it be T4 alone, T4 plus T3, or just T3? The most common approach is an initial IV loading dose of T4, maybe 100 to 500 micrograms, followed by a smaller daily IV dose until they can switch to oral.
Okay.
Adding T3 might be considered, maybe with T4, especially in younger patients without major heart risks, as T3 is the more active form, but it also carries more risk of cardiac side effects.
Right, and antibiotics.
Yes, good point. Given that infection is such a common trigger and might not be obvious immediately, broad-spectrum antibiotics are usually started early on too.
Covering the bases, it sounds like a very intensive, coordinated effort. What's the outlook like for someone who gets this, the prognosis?
Honestly, it can be pretty poor. There's a high mortality rate if it's not recognized and treated promptly and aggressively.
That's sobering.
It is. The outcome really depends on how severe the underlying hypothyroidism was, what other health problems the patient has, comorbidities, and crucially, how quickly treatment was started.
Are there factors linked to worse outcomes?
Yes. Being elderly, having severe hypothermia, and profound bradycardia, a very slow heart rate, those are generally associated with higher mortality.
So speed is key.
Absolutely. Early recognition, suspicion, starting treatment, presumptively thyroid hormone, hydrocortisone, and that comprehensive supportive care are all absolutely vital to preventing death.
And even if someone survives the initial crisis, are there longer-term problems? Complications?
Yes, unfortunately, there can be serious complications. Things like cardiac arrhythmias, abnormal heart rhythms, respiratory failure requiring prolonged ventilation, sepsis, severe infection, hypoglycemia, multi-organ failure, adrenal crisis if that wasn't managed, myocardial infarction, heart attack, and neurological complications to prolonged coma, potentially irreversible brain damage in the worst cases.
A really serious list. Okay, so just to pull it all together for everyone listening, The absolute key takeaways, the must-knows for revision.
Right. Think of it like this. Myxoedema coma, rare but critical. It's the endpoint of severe, untreated, or undertreated hypothyroidism. Key features to latch onto. Altered mental state, hypothermia, often that history of hypothyroidism.
And often a trigger.
Yes, often triggered by something like an infection or stopping meds. The absolute priority is early suspicion and immediate aggressive management in ICU HDU. That means IV thyroid hormone, IV steroids, supportive care. That's what improves the chances.
It really hammers home how important managing chronic conditions like hypothyroidism properly is, doesn't it?
Yeah.
Even things that seem quite stable.
Absolutely. It's a stark reminder about medication adherence, regular monitoring, all that fundamental stuff.
Make you think.
Definitely. And, if you are revising for exams like the MSRA or just want really solid high-yield medical info, do check out pathophysiology.com. Yeah, and there's also freemsra.com for, free resources too. Both are fantastic for nailing down complex topics like this.
Great resources. PathMSRA.com and freemsra.com. Perfect. Well, thanks so much for diving deep into this with us today. It's been incredibly useful for understanding such a critical condition.
My pleasure. It's an important one to know about.